The reality is that all humans are mostly the same between Western North Carolina and New York or Boston. There are cultural differences, and certainly the healthcare environment is different structurally in a lot of ways. But the things that drive behavior change for individual patients or the psychology of health systems there's actually more the same than there is different, is what I found. And to not be scared about scale and size, like the same leadership lessons from early days are mostly the same.
Welcome to the Move to Value podcast, powered by Chess Health Solutions. In this episode, Rob Fields, Executive Vice President and Chief Clinical Officer at Beth Israel Lahey in Boston, and Rebecca Grandy, Chess Director of Pharmacy, explore the clash between mission and math. How doing right by patients often means fighting outdated systems. They dig into the shift from fee-for-service to fee-for-value, what it really takes to handle downside risk, and why care delivery must evolve fast to meet rising demand.
Rob Fields, welcome to the Move to Value podcast.
Thanks for having me.
And I've been in healthcare now for almost 20 years. I've had the chance to work with a lot of leaders in healthcare, and there are a handful of folks who really have made an impression or have stood out to me. And you're one of those. So I'm really excited to have you on the podcast today. Yeah, so I'm actually going to tell a story, just sort of kick us off about how I first met you, which you may or may not remember, but it really left a lasting impression. It was about 15 years ago. We were both working for a health system in Western North Carolina. I was working for a medication assistance program. Yeah. And we were trying to, in addition to get people their medicines, we wanted to do something to try to improve health literacy, really empower them to take care of their health. And a colleague of mine reached out to you and asked if you would come be part of some classes that we were doing. It was after hours, just a handful of people. And that particular session was talking about, how do you get the most out of the visit with your doctor? How do you advocate for yourself? And you came just because we asked. You didn't get any credit for it, no titles, no spotlight, really nothing. But you came and you sat and you listened and you talked with people about how to engage, with their primary care and their other physicians, and really tried to help them feel empowered, in a system that can feel very overwhelming.
Thank you for that. I remember that program well, and it still is. I mean, hopefully it's still around, but it's a pretty amazing program, and you guys did a really amazing job as a great service to the community there.
Thank you. Well, and that moment has really always stuck with me because, that's what this work is all about. Value-based care, especially the more I get into it, the more complicated it is. Contracts, metrics, models. But at the end of the day, it's just about people and, people who care enough to sit and try to make things better. And so that's what I'm hoping to talk about today is some of the complexities, but also the people.
No, I'm excited to dive in. It is indeed complicated, but we'll do our best.
Well, I know you've worked in lots of different systems, healthcare systems, geographically pretty varied. Just how did you get involved in value-based care and what keeps you interested?
Yeah, no, thank you for that. And honestly, I feel like, like I said, I spent some time in New York and now in Boston, but the work we were doing in Asheville back in the day was only pretty amazing. It was amazing in lots of ways, but it was incredibly forward thinking and creative. In some ways that, I spent the rest of my career in these big cities trying to replicate, I think, the culture that we had there at the time, which I think was really unique and spectacular in lots of ways, so good for patients. But I got into value-based care mostly by accident. I think you may or may not remember back then, but 22 years ago in Asheville, I started a primary care practice with a close friend from the Mayhick residency program. We had played music together actually, and decided to open a new practice because it was taking multiple months to get a new primary care appointment. And although Rob Fields is not the most Puerto Rican name you've ever heard, I was actually born in San Juan. My mom's from Cuamo. I speak Spanish. And we opened a practice called Vista Family Health with bilingual staff and bilingual docs. And a big part of our practice was serving a Spanish-speaking only population. And I'm really proud of a lot of what we built. over the 7 years of being an independent practice in Western North Carolina, early with electronic medical records, patient portals, e-prescribing, all that stuff really early, before the hospital was doing it, before the residency program was doing it. And we provided a really great service to the community. It unfortunately was a total financial disaster for us personally. And we learned some really hard lessons about the impact of medical economics and healthcare policy on actually caring for patients. And I think as physicians, we think, oh, we'll just work hard, see patients, everything else will work itself out. And it just wasn't the case. We worked really hard. And it didn't work economically. And so it got me curious about root cause and why we're in the mess that we're in. Why it wasn't enough to just provide a good service to populations that needed it. And somehow the math didn't work. So I did get involved locally in state advocacy through the Medical Society and a few other leadership roles. Fast forward, and then also in operations and clinical leadership. But fast forward a few years, is probably 2013 or 14. I left Asheville briefly to take a job at the University of Florida and then came back. And at that point, Ron Paulus was the CEO of the health system where we worked at. Had come from Geisinger, had been in the value-based care space, obviously in Geisinger for quite some time, and really pushed us to start forming an accountable care organization. And at that point, it was still just a couple of years after the Pioneer program, if people remember that, and still early days in the ACO movement. But we did it. We're a group of three of us, really. Former health insurance executive who's still a friend, and a woman was an executive director, and myself as the CMO for the network. As we literally drove in a car and drove all over Western North Carolina recruiting docs to join our ACO, and it was great and built a pretty amazing team. A lot of folks that we both know well from back then, and had a lot of success. And I think after that is mostly just luck. We had some success locally. I got involved nationally with the National Association of ACOs, and through that process was invited to move to New York from Asheville, North Carolina. I think in season, Asheville at that point maybe had 150, 180,000 people in it, and ended up working in Manhattan, which was crazy. I remember texting my wife one day and said, "What do you think about New York?" And she said, "To visit?" Wow.
That's what I would say too.
Yeah. So we landed in New York, and it was great. And again, I just can't say enough. I think those lessons actually in pharmacy in Western North Carolina, amazing tradition between the extension of the UNC school into Asheville, and thinking about the Asheville project from 25, 30 years ago. It was really advanced thinking, I think, about how we care for patients and how we think about value in a clinical way, and how that then ties into economics. And I think relative to other people I was working with that inspired me, I was kind of behind the eight ball. I was just coming to it in 2013, 14, 15 or so, somewhere in that range. And I think really folks had been working on it in Western North Carolina for probably a decade before that.
Yeah, Western North Carolina, that's part of the reason that brought me to Western North Carolina. Originally from Western North Carolina, but a different part. Uh-huh. Went to Chapel Hill for school, but then I had heard about just the healthcare system in Western North Carolina, how progressive it was, how team-based care it was.
Exactly.
And so really wanted to be here, and have been here since, and really enjoyed a lot of the lessons that I've learned.
Yeah, no, I agree. It was a pretty amazing culture. And again, I think, the reality is that all humans are mostly the same between Western North Carolina and New York or Boston. There are cultural differences, and certainly the healthcare environment is different structurally in a lot of ways. But the things that drive behavior change for individual patients, or the psychology of health systems, there's actually more the same than there is different, is what I found. And to not be scared about scale and size, like the same leadership lessons from early days are mostly the same, and mostly just try to be a decent human being, and just trying to figure out how humans think and what drives behavior change is fairly universal. What is different is the politics, and some of the economic drivers are different, and the scale brings honestly more bad behavior than good behavior, I think. I think you think of the economics of health systems in New York City, it's really different. And in some ways, the level of competition made it harder for folks to think outside of the box because it was more at risk. From a market perspective, I'm thinking even simple things like how we think about endoscopy. One of the biggest cost drivers when we think about value is, hospital-based services versus outpatient or, outpatient services. I remember Asheville GI doing office-based colonoscopy in the early 2000s. I mean, going back 20 some years, and they were doing it safely with a high degree of quality in their office in a very low-cost way. And when I got to New York, the health systems were still doing in the hospital under general anesthesia. I'm like, this is crazy. We're so far behind. And there are plenty of maps and data to show that the Northeast in general, for all of the advances in technology and research, which are real, really unbelievable research and unbelievable innovation from a therapeutic standpoint, I think still very far behind on the value journey from a health services delivery standpoint. And just separating those two things. You can be very advanced in lots of ways, but I think how we deliver care is behind some of the areas that were under, to some degree, I think, more financial pressure back then, because we had a higher rate of government insurers. The rates weren't as high in places like North Carolina compared to these large urban environments. And so to some degree, the drivers for change happen a lot faster there than they did in these big cities. So as a pop health person, it's just different work. It's the same work, but we're starting from a different foundation than I think we were starting in places like North Carolina, where, I remember meeting with ACO leaders in Raleigh, in 2015 or so, and everyone's already and still thinking really forward. And even to put some data behind it, back then, I'm sure it's different now, but I haven't kept up with the North Carolina benchmark. But when we got our first shared savings check as an ACO, in our ACO, the cost per Medicare beneficiary per year was $7,800 a year.
Wow.
And it's more than double that in New York.
Wow.
And the outcomes are no different. I think some would argue a little worse, actually, from a mortality perspective. So there are lots of drivers for that, but I think the strong foundation of very strong primary care, how people view their relationship with their PCP was fundamentally different, how it's valued in the culture of healthcare, certainly in Western North Carolina, but I think across the state is really different than in the Northeast. Some of the things I mentioned about how we deliver care in what setting, I think all those things contributed to that, but it's a radical difference in cost. And so I think if you're looking at it from the outside in, you're like, that doesn't make any sense. It shouldn't be that way. And it's very easy to demonize the payers, and it's very easy to demonize the health systems for driving up costs. But it's so ingrained in the culture. It's really hard to separate. And it's too easy to sort of wave your finger, much harder to sort of figure out how do you actually change culture and behavior to have something different.
Well, and there's so much to unpack in what you said, but one of the things that I do want to dig into a little bit is culture. So I know that you've said that, culture and creativity are so important for value-based care. And so what things have you been doing, in your current position to get folks to embrace sort of value-based care and that culture over volume, over that fee-for-service, over, we can make more money as a health system if we have it, them do a procedure in the hospital versus an outpatient setting? Like, how do you counterbalance that, counterbalance that?
Yeah, I think some hard lessons of making a lot of dumb mistakes and a lot of failed conversations, like probably the classic story of folks that have learned over their career how, not to do dumb things and continue to do them. You do them once and hopefully not 2 or 3 times. But, I think the harder conversation in the beginning was to go to a CFO, a more classic, we'll say stereotypical health system CFO, and say, also sort of argue a moral argument to this. And folks that have heard me give talks before, certainly more so early in my career, I used to always have a slide that said, if the moral argument, we're if the moral argument were enough, we would be doing it already. And it's just not enough, unfortunately, just to say it's the right thing to do. That was really hard. I think that's hard for all of us to say, if it's the right thing to do, we should just do it. Well, sorta, except it ends up being more complicated than that, because there are questions of sustainability and all those things that come into play. And sometimes the way the system is set up, this is, I think, one of my big lessons from Vista is that we were doing the right things, and it just wasn't enough to actually still be around. And so if we wanted to be around, we had to get to the right thing probably slightly differently. And I think for health systems and CFOs, trying to just argue on the moral side just didn't work. And then started to think, okay, well, what makes more sense? And then try to argue with data. And so to your question on how we start to move folks, there are a couple of themes that I would say historically were true and are even more true now. So even the way I use my language is different now than it was even a few years ago. But the basic foundation is, at that point, we knew that a tsunami of Medicare patients was happening. People call it the silver tsunami, whatever you want to call it. At this point, it's 10,000 new Medicare beneficiaries per day. So if I'm talking to a health system CFO, like, this is your largest growing demographic. So you have a couple of options, and they're not mutually exclusive. So one option is I could ignore that and continue to do what I'm doing today in fee for service. You're guaranteed, most hospitals these days, especially post the pandemic, are nowhere near Medicare break even. So they lose money every time a Medicare patient enters the hospital for the vast majority of services. You could continue to provision care on a fee for service basis, and you have guaranteed loss. You're going to provide more of it, you will lose more, guaranteed. Or you could take a risk and think about a delivery and economic model that at least provides some possibility that you're going to generate a return. And you can choose, right? There's almost zero chance you're going to have Medicare rates be enough to cover your cost, but at least you can figure out a way to lower the cost of delivery of care, try to move to value, get some returns, and fund a different model and see if that works. And I think there was some progress made on that front if a CFO was really thoughtful enough, and again, creative enough to think outside of the normal way a CFO thinks, which is heads and beds, admit everybody that walks in the door. Mm-hmm. These days, I add a little more to it, because what's happening now, especially post-pandemic and after probably going into 22, into 23, where people are returning to utilize healthcare en masse. So the supply-demand mismatch is real. And, Medicare beneficiaries utilize hospital services roughly, depending on the market, 3 to 4 times that of a commercially insured patient. So as you grow Medicare patients, the demand on the hospitals is much, much higher. Unfortunately, at the same time, the workforce is shrinking rather dramatically. And the supply-demand mismatch and the capacity constraints is not really to some degree, it's a financial constraint, but it's really, in my mind, a capacity constraint, whether it's capital capacity, brick and mortar capacity, but in particular, a workforce capacity constraint. You have to solve for that somehow, and you can't force more volume through a narrow funnel that is the delivery of healthcare that hasn't changed in over 100 years, pretty much. For all the technology, you still have to make an appointment. You still got to drive to a clinic. You still got to get a diagnosis and a therapeutic in the office, wait a bazillion hours, and then go home. And you can't force more work into that narrow funnel from a capacity perspective. So I think creativity comes in. You're going to have to deliver it differently if you're going to still be around, because the demand is coming. And so how do we think about that differently? And I think that's where technology comes into play, remote patient monitoring, I think growing use of AI, growing use of team-based care members, clinical pharmacists, and others. I think we have to think differently and more creative in order to solve the problem, and then how the economics of a value-based environment at least provide some possibility for a return. So that's the kind of language I've been using in the last few years as the constraints become more real.
Well, and thinking about your conversations with the CFOs, and then just thinking about my experience, at Chess and with the clients and health systems we work with, early on in value-based care, most of it's shared savings. And that feels pretty palatable for people. It's like, okay, if I do well, I'll get some shared savings. as they move along that journey in value-based care, and now we find ourselves, in downside risk, I guess my question for you would be, how do you assess whether an organization is truly ready for downside risk? How do you sell that to them? Because, when you think about the market and value-based care, there are aggregators and companies that will essentially take on all the risk for the providers, right? Mm-hmm. And then there are other health systems that are taking that on themselves. So if you could just talk more about that move to risk and how do we know when we're ready for that?
Yeah, and I think so a few things. There's probably not one benchmark for one kind of delivery system. They're all a little different. If you're a large group of primary care physicians, that's a different calculus than if you're a health system with a bunch of specialists and a large sort of brick and mortar overhead structure that you have to contend with. So I think just to say that explicitly, it's really different depending on what you look like from a system perspective, large or small. I think there are sort of fundamental things like how you think about stop loss and how do you to some degree how you de-risk it. How do you take on risk by de-risking it to some degree? But I think more importantly and fundamentally is really the delivery model structure in the health system and how evolved is it? Because I think one of the things about risk is that I don't think for a hospital-based health system, we have hundreds of ambulatory sites. We have an exceedingly strong primary care platform here at Beth Israel Lahey, which is great, and obviously makes me really happy as a family doc and the chief clinical officer here. But we have a ton of specialists and other things here there, and so I think that if we take on full risk and have changed nothing about the flow of patients from primary care to specialty to hospital, or have thought about how we think about our ambulatory surgery strategy, for example, other side of service things where we're making intentional investments in areas that lower the cost of care, it's hard to imagine that we're fully ready to take on full risk without the appropriate infrastructure. And you can say, okay, well, it's chicken to the egg. Well, if you invested in the infrastructure, then you'll be ready. But if you wait forever, then you'll never be ready. And you're perpetually in this two-world thing that people have been saying since I got into pop health, the whole on the dock, with one foot on the canoe kind of thing. If I hear that one more time in a pop health conference, I'll probably explode. But we've been doing that for over a decade, right? Talking about the same thing. And that will perpetually be true unless you've made intentional investments on how the delivery of care needs to be different. And so I think part of the readiness is just doing a good self-assessment on what are the things I need to be doing from a delivery perspective to be successful in full risk. That usually means provision of care in a way that's less expensive than the normal way. And again, what's different now is we would talk about those investments. Really hard for your CFO to say, I'm going to accept a much lower rate in an ambulatory surgical center than the inpatient side. It's a dramatic fee difference. Why would I accept that? So what's changing now is that so much care is already going outpatient. You have to invest, otherwise you're going to be cut out. And so I think, again, the language is changing as the flow of care and the drivers of care are really flowing to other areas outside of the hospital for many reasons: capacity constraints, payer relationships, the role of venture and private equity in healthcare, which is sort of a mixed bag and can be really problematic. But if there is a silver lining, it has driven a lot of care in the outpatient setting in a way that's pushed health systems to think differently. So I think about all those things in terms of readiness. What really about the delivery model more so than anything else. And I think doing that intelligently. I'm not a fan. I think it's self-destructive to sort of, pull the pin on the grenade, if you will, and just jump into full risk because based on some ideological feeling that's going to change behavior. I just don't think that's the way it works. And I think you're more likely to put a lot of care at risk if you go foolishly into it. I think being thoughtful, it makes more sense. For example, in Medicare, makes a lot less sense in Medicaid, where the premiums aren't high enough to cover the risk and to cover the care in many states. Really challenging in commercial, just because commercial patients utilize differently. If you're a healthy 30-year-old, you tend not to utilize a lot of healthcare unless something god awful happens. You have some traumatic event or a horrible diagnosis, and then your costs go way high, but otherwise it's pretty low. And how do you plan for that? Because normally when you take risk, it's all about proactive management and avoiding that high cost care. That's really hard to do for a healthy 30-year-old because you can't predict it. So taking full risk in commercial, especially with small populations, which is often what we're being asked to do, not smart. So I think, taking risk, requires a lot of self-awareness, a lot of infrastructure investment on a different delivery model, and a strategy that doesn't, risk the whole process and do more damage than good by just going foolishly ahead for taking risk for all payers.
Well, I'm just thinking about payers. I know, at least from my experience being in primary care and then the providers that I know, when you have the patient in front of you, you want to treat them like any other patient, right? Regardless of payer, you want them to have the best care. I feel like sometimes behind the scenes, the reality of value-based care is very different, right? Like a Medicare Advantage plan is different than Medicare, is different than commercial, like you said, and thinking about the risk and the nuances. So I'm curious, in your experience, either now at Beth Israel Lahey or in the past, how do you create the infrastructure and the systems where you're thinking through all these different payers and contracts, but then you're allowing the providers at the time of care to sort of not feel that and it be more seamless, if that makes sense?
Yeah, absolutely. That's always the criticism, right? Is that the physicians and staff down at the office level in particular, but even at the hospital level, don't want to think in insurance. They just don't. They tend to have organ rejection as the thought of, I want to treat a Medicare patient different than, Blue Cross patient or whatever. And I don't blame them. So the key is to create models of care that work for both. And I get really excited about that. I mean, I think that the more we stop thinking about individual initiatives or individual contract-based interventions and think more about platforms of care that can be pointed in for lots of different strategies, the better off we are, because then you can be more payer agnostic. What do I mean by that? All right, so let's take the concept of digital care broadly, whether it's a virtual care environment or remote patient monitoring or anything. The way I try to talk about it is that it works for all populations because it can work for a concierge practice, so super rich, resourced patient that's a corporate executive and wants a digital care environment because they're too busy to be to wait 3 hours for us in the office. And so we have a digital care environment, whether that's a remote blood pressure cuff and a pharmacist provisioning care and writing prescriptions in between doctor visits. That's very high service, high touch, very responsive as a role. It works for a commercial population. Turns out works really well and probably better for a super poor Medicaid insured patient with lots of chronic conditions, because if anyone needs concierge care, it's a poor person in America, right? So if you can provision a digital intervention, because a lot of those folks actually have smartphones available. So if you can provide something that doesn't require their own Wi-Fi or their own data plan, but that it's built in, and you send them the same blood pressure cuff and the pharmacist is providing the same advice and managing chronic disease, it works particularly well for them because the challenge of trying to get to a doctor appointment and wait 3 hours for us to get the same care is even more challenging for them, because it's a luxury to be able to make an appointment and go and wait 3 hours. And it's a luxury a lot of folks don't have for one reason or the other. Either they lose wages or lose their job or trying to find childcare, et cetera, et cetera. Life gets complicated if you don't have means. And so it turns out digital care works well for both. So we can launch that same model, works for value-based care. It also works to grow our commercial strategy. We put a different label on it. It's the same stuff. And so then you don't have to think as much about, we're only doing remote patient monitoring for the commercial population, or only for Medicare for that matter. We think more of it as platforms rather than individual initiatives. And I think that helps a lot.
Well, and I love that. And then it also gets at the point, like, how do we implement value-based care in a way that doesn't increase disparities? So
Right.
I just sort of love your example of how this works better for people, even better. Well, the technology works even better for people who may have transportation issues or, can't be at the doctor for 3 hours. Are there other things that y'all have done to make sure that as we move to value-based care, we're not increasing disparities?
That's a good question. I mean, we measure is probably the best thing is that, you can have all the good intention in the world, but you need to be able to measure your progress to make sure that you're not. Because I think no matter what I say about intent, it kind of doesn't matter. You still have to measure and know that you're not having unintended consequences. Because to your point, as soon as you section off a segment of the population to do something with, you've messed with the ecosystem in some way, and it's going to have consequences. Not all of them are ones that you can predict. And so I think we constantly look at overall control. I think in the current environment, it's even more challenging to sort of think about how we get to the equal outcomes across all populations. But I was on a panel recently where I encouraged all of us to, my colleagues across the Boston area, and actually through to the state, was, we're not victims here, at least fully. We can still measure, we can still look, and the goals of providing the best outcomes for everyone that we care for is not only the right one, but it's still something that we can measure and openly do. And so that's what we look at, is we're looking for equal outcomes for all folks, and we have to measure that constantly to make sure we're achieving that goal, regardless of the other, the noise that's out there. But I think that's the big thing, is to hold us accountable by continuing to measure.
This has been the Move to Value podcast, powered by Chess Health Solutions. We hope you enjoyed this episode. Join us next time for the conclusion of the conversation between Rob Fields and Rebecca Grandy. To explore this episode further, or check out past episodes and resources, head over to movetovaluepodcast.com. While you're there, you can sign up for email updates so you never miss an episode. If you're enjoying the podcast, be sure to subscribe on your favorite platform and consider sharing it with your network or leaving us a rating or review. Thanks for listening.